Greetings. Thank you very much. I'm going to be talking about implementing a radiopharmaceutical therapy program. So first of all, the question that we have to ask is, what is radiopharmaceutical therapy? It's not a new modality, but it's something that has seen a really great increase of interest in the last 5 to 10 years. It's known by many other names: therapeutic nuclear medicine, theranostics, radionucleide therapy, and so on and so forth. Basically what it is, it's a radioactive drug that's administered for therapy. And as I said, this is something that has shown a huge resurgence of interest, and in fact the NCI is anticipating that within the next 5 to 10 years, about half of all of radiotherapy will include radiopharmaceutical therapy. That's not to say that it will take the sole place of things like external beam, but it will be another additional weapon in the armamentarium against cancer, and it is expected to be used a lot more than it is currently. At AAPM, of course, we're also on the riding the wave of this resurgence of interest, and there was a creation of an ad hoc committee for radionuclide therapy a couple of years ago. We've made pretty good progress so far. We're still awaiting a decision on the permanent placement for our committee, but we are actively involved in trying to work, especially on education, on documentation. I'm the chair of that committee. If you would like to reach out, this is my email. So what am I going to talk about today? I'm going to basically divide this into two parts. The first part is going to be basics for radiopharmaceutical therapy, what to do with the current paradigm of administration, which is activity-based, mostly fixed activity. Take a look at what the drugs are, specific ones, what is the role of the physicist, and talk about radiation safety mostly. And then the second part, we're going to be talking about more advanced implementations when we start to use dosimetry. How do you do it? Why would you do it? And what the current status is. All right, activity-based administration. So these are the current radiopharmaceutical therapies. This first one, radium-223 dichloride, was really the flagship of this recent surge of interest. It was approved in 2013. It's an alpha emitter. Radium-223 doesn't need additional targeting agent because it is in the same chemical family as calcium, and so it goes to bone or bone calcium bone metastases, and so it's been approved for metastatic castrate-resistant prostate cancer. And here you can see the overall survival benefit in this phase 3 trial, which justified its approval. Another one that's more recent, although it's been used in Europe for 10 or 15 years, recently approved in the United States, is lutetium dotatate, something you've probably heard a lot. Lutathera goes by the name of. It's targeting somatostatin receptors for neuroendocrine tumors, and here you can see the overall survival benefit. This is a beta emitter. The energy is lower, so the energy for the alphas was 5 MeV. Here the Q value of the beta emitter is about 500 keV. For those of you who don't remember what a Q value is exactly, remember that beta emission is when a proton changes into a neutron. A neutron changes into a proton, and to conserve charge, the electron is emitted, which is the beta emitter, but because it's a lepton, there needs to be lepton conservation. There's also an antineutrino that is emitted, and so it's a 4-body decay process, and so the distribution of energies is not always fixed, and so beta emission has a range from 0 to 500 keV, and the average is about 1/3 of the Q value. All right, an oldie but a goodie, I-131 sodium iodide for thyroid cancer. That one's been around since the 1940s when it was first proposed by Saul Hertz. It's also a beta emitter. It also does not need a binding agent or a ligand. Iodine is naturally taken up in the thyroid and in thyroid cancer. Something that is kind of on the edge of what radiopharmaceutical therapy is, but has been around for 10 or 15 years, yttrium-90 microspheres for liver disease. It's been approved as a device rather than as a drug because it's actually microparticles. It doesn't have Avogadro's numbers of molecules. It only has 10 million microparticles, and it's actually injected locally rather than systemically. It's injected into the hepatic artery, and since they're small particles, they embolize in the arterioles, and here you have a picture of arterial branching of the liver. There's no redistribution of activity, basically speaking. So how does this work from a targeting standpoint? Well, it works because the liver has a dual supply of blood. And the normal organ actually gets most of its blood from the portal vein, whereas the tumor preferentially takes its blood from the artery. And so that's how you get a preferential targeting of this treatment. So it's a pure beta emitter with almost no associated photons, and its Q value is quite high for a beta, 2.0. All right, another one that's come around more recently is I-131 MIBG for several different diseases, pheochromocytoma and paraganglioma, high-risk neuroblastoma. Again, this is the same Q value as the I-131 on its own, and this is being used for adults, but also for pediatrics. Another one that is hasn't been approved yet, but it is being worked on is PSMA targeted therapies. There are multiple different small molecules that target PSMA for castrate-resistant prostate cancer. They're in different phases, phase 1 through 3, produced by the same company that has Lutathera. Some of them, there are others, they're produced by other companies. And here's an example of a treatment where you see what's happened after treatment of this product. Okay. All right, so what do you need to prepare if you're, so as I said, the interest is really big, not so much among the physicist community, but in the physician community, both in radiation oncology and in nuclear medicine. There is a huge interest in using these new therapies, and so it would not be surprising if your physicians come to you and say, we want to be able to do this, how do we do this? So these are the basics. You're going to need to get your radioactive materials license. You are going to need facilities, and we're going to go through these items one by one, depending on what type of modality you're going to be doing. You're going to need different facilities. You're going to need to identify your key personnel, standard operating procedure, safety precautions, and of course you want your documentation forms the same as you do for any other therapy procedure, written directives, medical physics checklist, dose calibration QA, treatment summary, and patient discharge instructions are really, really important in this field. Okay, so when we talk about establishing documentation forms, we're going to start to take a little bit of the differences between the different departments. This is really from a radiation oncology paradigm where we're used to having a much higher level of rigor in QA and procedural form. You want your written directives, you want to have the medical physics checklist. Whereas in the nuclear medicine paradigm, where they're typically more used to diagnostic, the level of quality assurance is not as high. They don't necessarily have written directives, and it needs to be, you know, if you're supervising a program, and you're in nuclear medicine, you would maybe try to engage your radiation oncology colleagues to see what kind of quality assurance and directives they have. Often in nuclear medicine, the drugs are actually being administered by the technologists, and that can be a good thing. And this goes to the personnel issue, because they're kind of like therapists in external beam. There are a lot of them, and they do the hands-on stuff, but at the same time, you don't want them to be the one that is ultimately responsible for the dosing of these products, especially as you move towards dosimetry-based treatment plan. But even in fixed activity, this is something where a physicist should be involved. Again, because there are interests from different departments, sometimes this can lead to conflict and turf wars. The societies have met at both ASTRO and SNMMI at the leadership level and are really 100% on board, agree that they want to pursue this together as a cooperative venture and try and share experience and expertise. Obviously, nuclear medicine understands best the pharmacokinetics, but radiation oncology has a much stronger use of dosimetry and understanding therapy in patients. The medical oncologists deal with the patients and supply the patients. So, in fact, ideally, at the institutional level, you want to have an MDC type approach where the patient is put at the center of care, and you have, you know, all of these people that are coming together to help treat the patient. Again, you really want a lead physicist, even if you're working in nuclear medicine, not necessarily to administer on a daily basis, but at least to supervise. And of course, you want your radiation safety officer involved and your nurse. So your radioactive materials license should work with radiation safety for this. If you get a broad scope license, that's probably the best option. It's valid for all isotopes up to lead. Above lead, so for the alpha emitters like radium-223, you're going to have to put in a separate request for that specific isotope. If you don't have a broad scope license, you're going to have to specify each and every isotope that you want on the license and the amounts. Be careful, some states also require that you have a license for the isotope contaminants. So lutetium-177 has a lutetium-177M contaminant, actinium-225 is an actinium-227 contaminant, and those are sometimes required. Again, you need to check with your individual state. You may need a separate license for each facility. If you have multiple facilities, authorized users must be listed on the radioactive materials license. Currently, you do not need additional training or certification as a physicist beyond your ABR certification to engage and provide, the oversight for these treatments. That may change, but that is highly unlikely. Mostly what we're looking at is to educate people with these types of sessions. Of course, anytime you interact with the government, it will take a long time to get change, and the same thing is with billing. It could take forever to set up. So start early. All right, so let's take a look at different types of specific types of products and what levels you're talking about. When you're talking about alphas, and we're going to take the example of radium-223, alphas have a very short range and are absorbed very easily, and you're giving low amounts of activity, and so the logistics are very simple. You just need an outpatient treatment room. They can just sit on a chair. They need 30 minutes. You inject the drug, and they go home. That's basically it. So you order your activity based on the weight of the patient, 1.49 millicuries per kilogram. It's delivered to you in a pre-measured syringe. Obviously, you're going to double check that activity in your dose calibrator. Sometimes you have to thaw and draw if you're in Europe. The company that distributes this, Bayer, and I am going to mention them because they're, again, as there is a bit of a dichotomy between nuclear medicine and radiation oncology, there's also that same type of dichotomy between companies that provide drug, in that some are more therapy oriented and some are more diagnostic oriented, that have converted to therapy. And Bayer is a more therapy rigorous type of company. They will send you a NIST traceable standard with instructions on how to calibrate your dose calibrator from the get-go. Now, all of these drugs have to be administered within have a 10% window, or there's a misadministration. And so one of the tricks with the radium-223 is that because you're ordering based on weight, you need to weigh the patient and make sure that the amount of activity that you have fits within the 10% window of the current weight. The other slight trick is that there's only a 96-hour sterility window for Xofigo, and so what that means is that includes shipping time and production time, and so unlike with brachytherapy, where you're used to getting your seeds 2 days in advance, often you will get it the day of, or if you're lucky, the night before. And so you have to do your documentation and preparation within a relatively short time. Luckily, it's a very easy preparation to do. Safety concerns are, as I said, there's really nothing in terms of exposure. Alphas are 50 to 100 micron travel distance in tissue or water, which means that it's blocked by anything that contains the liquid. So the syringe and the catheter, even if you get it on your hands, the alphas will be absorbed by the dead skin cells. The only concern you have is really contamination and ingestion. Radium-223 goes to bone. Half of it is excreted over 1 to 2 days, so a little bit more slowly than most radiopharmaceuticals, and differently than most, a lot of it comes out in the feces, whereas most others are exclusively in the urine. The half-life is 11.4 days. So you take an exposure measurement pro forma, because NCR guidelines say that you have to keep a record of this measurement for 3 years. But again, it really is not an issue. the written guidelines that you're going to give to these patients concern mostly how to limit this contamination and ingestion, such as making sure that they sit down when they go to the bathroom, that they flush the toilet twice, that they wash their clothes if there's any leakage, and so on and so forth. The concern you might also have is infiltration or extravasation at this point, so you need to monitor closely as the patient is being injected that this is not happening. Currently, this is not considered a medical event, but the NRC is currently looking at changing that, so that may change in the near future. All right, level 2, a little bit more complicated. Some of the newer lutetium ones, so dotatate is probably the one you're thinking about most. You need an outpatient treatment room where the patient is isolated. It can be lint-lined, or it could only just be separated far enough from other areas. Again, if you do the measurements and calculations, that may be enough. Consult with your radiation safety officer. So the patient is going to be there from 3 to 5 hours and is going to be voiding into the bathroom, and so this is where you risk getting contamination, and so you're going to want to pad as much as possible. This is actually one of our earlier photos. Later on, we put chucks along the back wall as well. Right. Administration is mostly gravity drained, so it's an interesting method where the needle to your saline goes in to the vial above the level of drug, and it drips in there, which creates pressure, and then that pushes the drug up through the long needle, which is below the level of the drug, and into the patient. Or you can use a syringe pump. Fixed activity also here, 200 millicuries, 4 different cycles. AAA is the example of the company that has evolved from diagnostic and is not necessarily as rigorous as you would like them to be. They will send you activity. They won't necessarily tell you that it's traceable or no indication on how to do your dose calibration. Of course, that's not that difficult, but you want documentation for traceability, and it's really hard work to get them to send it to you, and their traceability currently is to the National Physics Laboratory in the UK. The other thing that they do is they'll take advantage of the fact that they know that you have a 10% window, and if they don't have enough activity concentration, they'll only send you one vial and say, well, there's only 190, but don't worry because, you know, you have a 10% window. Anyway, for info. Safety concerns. So, of course, you have the same concerns about excretion and contamination as you did for the level 1. But you also have to be concerned about exposure from the photons. So the excretion here is about 50% in the first 2 to 6 hours, and you want to keep these patients during that time until they get rid of this. The half-life is 6.7. The associated photons, like I said, relatively low, 100 to 200, and also relatively low branching ratios, 5 or 10%. So release criteria are in the regulatory guide 8.39 of the NRC, but they are currently working on revision 1 because specific values for lutetium do not currently exist. They really only have the older isotopes in there. And the IAEA also has a report that you can check as well. So the typical criterion, if you're taking a look at the exposure rate, is about 2 milliröntgen per hour. That's somewhat conservative at 1 meter. The value that you need to keep in mind is that you are not to exceed 5 millisievert from the patient to family or public, and of course the person that you're most concerned about is the direct caregiver, because they're the one that's going to be most closely to the patient from this exposure. And so what we do often in the United States is that we release them relatively early, and we give them instructions in terms of, well, in order to reduce the amount of exposure to your caregiver, is that we're going to give you a length of time that you can't sleep with the partner. We're going to give you a length of time that you cannot visit with your children. You can use an Excel spreadsheet for that. Some software is available. So that's something that you should think about, just working to Excel spreadsheet. The calculations are fairly simple, but it's good to have that calculation as well. Once the patient is released, he's no longer your responsibility. What does that mean? This is a question you get very often because people are concerned with this. Well, you know, there's radioactivity in the patient. What happens if the patient goes and bleeds on somebody and then they're radioactive? Once you have released them, they're not really your responsibility. You have responsibilized them by giving them written guidelines, which is required also for a certain threshold of criterion, but that you shouldn't really worry about. You should just give people written guidelines all the time, regardless, no matter what. but you really can't control them. I mean, if the first thing they want to do when they leave the hospital is go and urinate in the public, park, then there's really not much you can do about it. The one exception is, of course, if they die and they come back to the hospital, and then you need to do calculations and concern and work with the autopsy team if that's needed, or at least the patients that are taking care of the staff that are taking care of the body, or cremating or whatever, in order to help them along that. All right, level 3, this is really hardcore. I-131 MIBG for pediatrics. This requires a whole lot of preparation, and to be honest, we don't do that at our facility. This definitely requires a lead-lined room. This is almost the equivalent of a typical therapy external beam or HDR, except for the patient is going to be there for 3 to 5 days. Now, of course, the lead lining isn't going to be nearly on the same level that you have for external beam or HDR. But you are probably going to want to have some amount of external monitoring, so you don't have to go into the room every single time. And within the room, you're going to have portable shields. You need to put your absorbent pads everywhere, and especially if they're pediatrics, you're going to get emesis, you're going to get excreta of all shapes and colors. The care providers are going to wear PPE, and they're going to wear dosimeters as well to monitor their exposure. The injection is here in a syringe pump, and because everything is at such high activity, it is being put in a shielded pump. The activity is on the order of 10 to 18 millicuries per kilogram, depending on the protocol, depending on the disease being treated. And of course, since there are pediatric patients, often you will have to have anesthesia in there as well. So that additional complication. So that requires a huge concerted effort from all the teams. I mean, you really want to educate and work with your nurses in the ICU, your anesthesiologists, monitor them well with radiation. Like I said, there's a high level of activity, but also the very high energy photons, 364 with an 80% branching ratio, and 636 keV with 7% branching ratio, a half-life of 8 days. So you need to also control the exit of material from the room, and the best way to do that is have a place where they're stored by the door, and then a couple times a day, the radiation safety officer, the physicist will go by and scan the material to make sure it's safe to exit. Again, very, very delicate and tricky from a radiation safety standpoint. So the value here is actually given, because it's a relatively old isotope, is 7 millirem per hour, which is very low. Do not recommend using that values, but using a calculation based on the 5 millisieverts. An effective half-life has been calculated on the order of 24 hours. If you use 7 millirem per hour, as they do in Europe, you end up keeping even your iodine 131 sodium iodide patients for thyroid cancer as inpatients for several days, as they do in Europe, because it's that low. All right, so how do we go now to absorb dose administration? All right, so what we've seen, all of these activities are based on fixed activity or maybe weight, and so it's basically like chemotherapy, except for it's radioactive, and that's kind of how they dose escalate. They give in their phase 1-2 trials, they give more and more activity until patients, they start to see toxicity, and they say that's the total amount of activity we're going to give patients. But we know that this is radiation, and so the damage is by dose, not by activity. And we know that it's a product, actually, of the amount of activity you put in. Of course, that's one of the factors, but it's also based on the amount of retention of the drug in the different organs. And so this area under the curve, which is represented, you see a huge difference between patient 1 and patient 2. So how would you do dosimetry-based treatment planning, since we know that dosimetry is the language, is the physics metric for damage to normal organs? Well, you would administer a pre-therapeutic amount of activity, possibly as a surrogate, and then if you have like a pair of like gallium-68 and lutetium-177, you call it theranostics, but maybe the same drug itself. And then you image the patient over several days using SPECT or PET images, and you take a look at the different pharmacokinetics. You count for the change in isotope between the pre-therapeutic and therapeutic if you have to. You calculate to dose 2 organs per unit of activity, and then you scale to the different organs and determine which organ is the dose-limiting organ, what that MTD is, and you can obtain the administered therapeutic activity. This is just not this is the way that it should be done, and it's more intuitive to us physicists than it is to the physicians, especially those from the nuclear medicine or medical oncology community. But this is just not a theoretical concept. I mean, this is something that the APM, SNMMI, ASTRO, IEA, NCI advocate as the way this should be done, in spite of the fact that currently everything is done based on it. So the first question you want to ask is this really going to make a difference? And the example I'm going to show you is probably the first one where dosimetry used for individual treatment planning way back in 2003, I-131 anti-CD20, which you may remember as Bexar, where they had demonstrated that 75 centigrade to the whole body it was a good surrogate for red marrow toxicity. And so how do you get the 75 centigrade? Well, the dosimetry is rather crude because you're using just whole body, but this showed that the amount of activity injected to obtain those 75 centigrade varied tremendously. Here you see from between 50 to 150 millicuries, and some outliers going up beyond 250. And this is not atypical. This is just standard. A factor of 2 to 3 variability is normal and not pretty common to see up to an order of magnitude of difference to normal organ dose as a function of the patient. It's just, it is a huge factor. And so the other thing that you want to consider is, okay, is it going to be predictive though? If we do these pharmacokinetics for an individual patient, are those pharmacokinetics going to repeat themselves such that when we give the therapeutic amount of activity, are we going to get the dose that we expect? And now the examples that I'm going to show you are not typical. They are the most extreme, the most difficult ones, and the least predictive. And one of them, the first one here on the left, is the lesion, so the tumor dosimetry, which is not as critical because obviously that's not the life-threatening part, but still shows very good correlation. This was done for I-135 radioimmunotherapy, so similar type of product. I'm not sure if it was the tositumumab or the ibertumumab dioxetan, but similar to the type of treatment for, as we saw in the previous slide. And then the other one, the most difficult organ at risk for radiopharmaceutical therapy is bone marrow. Like when you do liver and lungs, they're easy to contour and do the dose for. The bone marrow is distributed and at a very small scale and below the imaging resolution, often in most parts of it, of the images. So it's probably the hardest one to do, and although the correlation is not great, it's still reasonable. And for the easy organs like the liver and lung, the correlation is actually very tight. All right, so to understand now why we've understood why we want to do it, the question now is how are we going to do it? And so there are two methods we're going to look at. The basics, one is the activity-based with phantom-derived S values, called the MERD method, and the second, which is known as the voxelized method, which is using dose rate based, using direct or indirect Monte Carlo with patient-specific anatomy. Now, they have a lot more commonalities than you would think, because most of the time the emphasis is put on their differences. You need the multiple time point 3D in vivo emission and transmission images, that is, say, SPECT-CT or PET-CT. You also need, so obviously you need good activity quantification, and of course you're going to have register those images, and you're going to have to segment what you're looking at. So those are the commonalities. All right, so the absorbed fraction method is the idea that here we're looking at, for example, the liver, and that the dose to the liver is the sum of the contributions of dose from all of the organs that have uptake of activity, including, of course, the liver itself. And each of those contributions is the number of disintegrations in those source organs, so let's see here, the lungs, multiplied by the energy released per disintegration, which is just a property of the isotope, multiplied by the fraction that is emitted in the source organ and absorbed in the target organ, and divided by the target mass. And you sum up all the different contributions, and then you get your dose. And what the MERD committee did a long time ago now is that they took a look and they said, you know, this delta is constant. It's a property of the isotope. That's the energy per disintegration. The fraction of going from one organ to the other should be pretty much standard for a standard human being. And, you know, the mass, if you use reference human values, is going to be about the same. So if we do Monte Carlo in a very schematic, idealized geometry for all the different isotopes, we could create these S values which means that at this point, the only thing you need to do is measure the number of decays, which is the time integrated activity, and multiply by all these values to get your dose. So it's basically a coefficient that converts the time integrated activity to dose based on idealized Monte Carlo. And this is the same concept given to me by a colleague at the University of Iowa, Stephen Graves. So a bit more modern concept, and basically here you see the input of what he calls residence times, and that's actually the time integrated activity coefficient normalized to the amount of administered activity. Used to be called residence time, now we're supposed to call it time integrated activity coefficient. You multiply it by these S-value matrix and you get the doses on the outside. And the other thing I want to show you here is that the phantoms used for these calculations have evolved tremendously. Now they are much more realistic. You have spline models, mesh models, voxelized models. And the other thing that I want to mention is that the common misconception that this is only works for organs, whereas actually the S-value method works for any region that you care to define. Most of your software will only be concerned with organs, but this is much more versatile than the other method. And we're not going to talk about alpha dosimetry at all, but alpha dosimetry is very difficult because the range is so short, and if you have localization of uptake at a scale that's below the imaging resolution of your SPECT or PET, you really don't know what's going on. So the only way to deal with that is to model and use the S-value method. All right, so the only thing that's left is for you to find the time integrated activity, that is the number of decays. So how do you do that? You get your images. In theory, you could get them from planar using anterior-posterior methodology, but please do not do this. The uncertainty is incredibly high. It's very artistic, and there's a history of having bad dosimetry being done with this. You want your 3D imaging. And then you take this patient images, you contour either from your voxel to your organ level or region level, whatever you want. And of course, then you take the area in each of those after you've registered them, and you take the area under the curve in whatever region you want, and the area under the curve is your time integrated. All right, the second method is you do the same thing, except for first, before you or after you register, but before you draw the areas and take the values inside, you run individual Monte Carlo on each of those time points. And so what you have then is dose rate at different times. And then the area that you have decided upon, whether it's an organ or a voxel, you take the area under the curve, and that directly gives you the dose. So the advantages are, obviously, there's no dependency on the modelized anatomy, although, again, the S-value system is more versatile than people give it credit. You can scale those S values to different organ sizes. But the real advantage is that, of course, that since you're still working with a phantom, you don't have tumor dosimetry in the absorbed fraction method unless you have to do it separately, whereas, of course, in the individual patient, you have tumors, and so you can do tumor dosimetry at the same time as your normal organ dosimetry. And because you can also do this integration quickly at the voxel level, this is often termed voxelized dosimetry. This is an example. So for a long time, this was only done at research institutions with personal software. Now there are commercial software available that can help you do this, and of course they don't want to spend the whole time to run entire Monte Carlos, and so they use simplified approaches. And one of the more popular ones is a kernel convolution, where you just create an energy deposition kernel for your isotope, you convolve it with your activity map, and the result is your dose map. And this slide has also been provided by Graves. All right, so these are the current FDA-approved software. These first two, it's from the same company, use that absorbed fraction methodology where you type in your time-integrated activities and get out the doses. And the last three give you the voxel-wise results. And this is an example of one. They're very similar. So you get a display of the images, quantification of the activities. You can do the registration, they have segmentation, and then they will integrate and do the dose kernel convolution and give you the dosimetry. One of the things that we want to look at, and this is not specific to this particular one, they all do the same, is the fitting of the curves. And so this is something you want to think about. Of course, the software will fit the curves for you, but it's based on your points, and so you need to be thinking about, okay, what time points do I need? How many do I need, and what times are going to be important relative to the isotope and the radiopharmaceutical that I am looking at? Okay, a few comments now. You need to understand, as I said, both of them depend on accurate image quantification, and so you can get these more and more commercial SPECT CTs are getting decent reconstruction in their software, and so you can get good results, but oftentimes you only get counts and you have to do the quantification yourself. Remember, just published several pamphlets, including Word 23, which does a very good job of explaining the basics of how to get this done, what different spectra you should be using. This is how to correct for scatter using the triple energy method, if there are dead time corrections, what collimator choices, what reconstruction method iterations, response functions, etc., etc. One of the important things to remember, so this is an example down here of lutetium, where this is the idealized phantom and the reconstruction using one energy, that the 100, and this is the 113, and this is the 208, and then if you add those two together, you get something that's a little bit better. One of the things that's important to remember is that these images, even though they are at the voxelized level, and so people like to think, especially with the voxelized dosimetry, that you're getting good, accurate dosimetry at the voxel level, the activity quantification itself has a definite limit in terms of how low it can go, which is on the order of maybe 5 millimeters. And what typically happens is it will still quantify well, but it will not localize necessarily the activity in the right place to within 5 millimeters. And this is known as the partial volume effect. And so you need to be careful when you start looking at smaller objects. And some ways to get around this is to use recovery coefficients, but then it becomes dicey because you still have the activity on the outside, etc. Related to that idea of how low you can go before it becomes reliable, one of the major issues in dosimetry has been the fact that nobody has ever published any values with uncertainty. Nobody knows how much it is. That is until the E&M came out with a publication a couple of years ago where they went to the Joint Committee of Guides on Metrology and they based their uncertainty calculations on the GUM. The guide to the expression of uncertainty measurement, and using the law of propagation of uncertainty, so you identify what your sources of uncertainty are and how these propagate to the uncertainty on the absorbed dose. So this is a huge result, and so we have a methodology now for error bars. So the most important results here is that we should be publishing. When you do research and when you are publishing papers, you should be giving error bars using these methodologies. Now, of course, we know that in the clinic, we don't give error bars on doses to patients, but it also gives you a good indication of where the sources of error are and how you should be reducing and where the QA needs to be. And although I mentioned the theoretical limit is really on activity quantification, in practice, the greatest source of uncertainty, and especially that limits how low you can go, is the how the volumes of interest are delineated, the segmentation, and that for anything, and I'm saying here for tumors, but even for normal organs that are small, like lacrimal glands or whatever, the biggest issue is contouring these accurately, and below 8 or 10 milliliters, there is a lot of accuracy. So now I want to talk a little bit about radiobiology. And I'm getting close to the end of my time. EBRT, one of the things important is voxel dose is uniform. And even though I mentioned this, even though we give voxel dose in RPT, it's potentially non-uniform because you can't see the uptake is driven by physiology, whereas in the dose in EBRT is driven by the geometry of the beams. And so sometimes you can get uptake even though it mostly looks like your normal organs are uniform because, you know, it doesn't vary from one side to the other. Sometimes it can be driven by cell type or FSU uptake, and so this can make differences at the small scale. Classical example is salivary gland toxicity for I-131, where if you do the absorbed dose to the entire organ, you would think that there's not enough dose for toxicity, but really because the uptake is in very specific cells and the linings of the ductal cells, you get a lot more dose to specific cell types and you see toxicity at much lower organ averages. So one of the things we need to understand, of course, is that there's a lot of biology going on here. Dose is the physical quantity, but there's no biology going on. And this is more of an issue in radiopharmaceutical therapy. We know that in external beam, dose given at 2 gray is not the same as dose given at 3 gray or given at 4 gray, and there's the Withers formula for going from one to the other to figure out the equivalence. In radiopharmaceutical therapy, this variability happens not between modalities, but from patient to patient. But because we've seen that the pharmacokinetics are different for each individual patient, that means the rate at which the dose is given is going to vary from patient to patient. And so a dose to one patient will not necessarily have the same effect as a dose to another patient. And so even though I said I advocated absorbed dose-based treatment planning, really, and I've said this also, there should be dosimetry-based treatment planning, because you have to normalize to a standardized dose, and you can either use BED or EQD2. The other thing to understand is that there are variations between modalities, sometimes that aren't necessarily known. Like I said, you can sometimes have these very localized uptakes. The classic example is yttrium 90 microspheres, where the prescription dose is 120 Ray to the normal organ, which makes no sense in external beam terms. The other thing you want to be careful of is combination therapies. So this idea of dose, you need to understand what biological dose you are talking about, because another thing that people do is they want to say, well, 23 Gray to the kidney is the limit, is the MTD in external beam, but we can see, strangely enough, in radiopharmaceutical therapy, that we can go much beyond 23. Well, yes, because you are not calculating your grays in EQD2. If you were to calculate your dose in EQD2, then you will see that you still have a limit that's probably pretty close to 23 Gray of EQD2. And the other thing you need to take into account is when you start to combine these, which people do a lot, of course, with other things like chemotherapy and PARP inhibitors and all kinds of things, that you're looking for positive synergy, but sometimes you can get negative synergy. And so sometimes your threshold for dose will be affected by the other things that you're giving your radiopharmaceuticals. All right, so this is the example, the seminal result from the Université Catholique de Louvain, published by Barone et al. in 2005. They took a look at the correlation between kidney dose down here on the x-axis and creatinine clearance loss per year as their metric for toxicity, and they found nothing whatsoever. And then they said, wait a minute, we can scale these phantom values properly by putting in the individual patient kidney mass, and they got something a little bit better, and they fit it with a curve which I think is fairly generous. But then they said, wait a minute, the dose rate is going to be different from patient to patient. We should normalize to a standardized biological quantity, which here was the biological effective dose, and here you can see the correlation is much tighter. And so this really shows the practical proof of what we were mentioning as kind of a theoretical concept, that you have to normalize to a biological dose rather than just absorbed dose. And this was taken a step further by MER20 when they said, let's take those results from Barone and let's compare to the external beam data using these standard Withers type formulas. And here you can see that the numerator here is slightly different because the value for radiopharmaceutical therapy includes a correction factor. But the point is that they overlap. So dosimetry is not just absorbed dose, it's just the starting point. There are pharmacokinetic models, small scale dosimetry, the range of isotope, size and number of tumors, disseminated disease, and so on and so forth. But of course you can't do any of that and take it further unless you start by calculating the absorbed dose. Other reasons to do dosimetry, not necessarily prospective. You can do retrospective dose-effect correlations. Those are really important. Provide a database of activity to show and convince yourself that activity and dose is not the same, and that if you give fixed activities, you will get a huge range of dose, and you will be probably underdosing most of your patients. Dose reporting is really important as we move to combine with external beam. If the patient after radiopharmaceutical therapy goes to external beam, ideally your physician is not going to want to know that the patient received 200 millicuries of whatever product, but what dose, and even better, give them a dose map in EQD2 of the product that has been given. All right, so in conclusion, radiopharmaceutical is headed our way in a really big way. As I mentioned before, physician interest is already very, very high, although most of them are generally only interested at this point in fixed activity administration. So it's going to be up to you to help them set up the programs, but it's also going to be up to you to help them generate interest and understand the advantages and the importance of using dosimetry to treat these patients. Be aware of the potential differences in approach between radiation oncology and nuclear medicine. Really encourage you to work together across departments and collaborate. Radiation safety is definitely the main concern for your activity-based administrations. So the strategy here is you want to learn the radiation safety and be comfortable with your activity-based program, and then start, before you jump into dosimetry-based treatment planning, do some basic dosimetry and retrospective dosimetry with some of those other things I mentioned, like tumor dose effect correlations. And once you start to get confident and see that how important this is, then maybe you can work at doing treatment planning. There are a couple of guides that are going to be coming out. The MERD committee is going to be publishing their primer this year. The IAEA is publishing a huge document as well this year. The ICRU report 31 should be out this year. So there will be some major guidelines published within the next 6 to 12 months on how to do dosimetry in radiopharmaceutical therapy. All right, these are the people that whose slides I borrowed. Anna Kies, my colleague, and Stephen Green, as I mentioned his name a couple of times. Thank you very much.